This is another Puscast covering the first 2 weeks of December 2014. As always, the references are at edgydoc.com, as well as links to my growing multimedia empire. But you're probably not interested in this babbling forward, so let's move straight on to the literature, shall we? While fundamentally I think I'm an optimistic person, the fan is spinning fast, and we are shoveling huge amounts of fecal matter at it. As an example, look at multi-drug-resistant bacteria. When I started practice in 1990, everything was susceptible. MRSA, VRE, etc. were all things of curiosity, and now they're common. They now estimate that by 2050, drug-resistant bacteria might be killing 10 million people a year. Now, you always kind of wonder about these kinds of projections into the future, but this is one that seems fairly realistic to me when I watch how antibiotics are used and misused by others. That resistance, as the Borg said, is inevitable, and we'll probably go from the 50,000 a year in the United States and Europe who die of MDRO to even worse numbers as time goes by. People get all Wiggins about things that are of probably little importance to the United States, like Ebola, but don't seem to do much about the things that really matter, like drug resistance. Welcome to the human species. So I had thought that the data suggested that HIV was becoming more virulent, at least in the United States, with less opportunity to be passed on due to safer sex and highly active antiretroviral therapy. Only those with higher replicative rates and higher viral loads, and subsequently more rapid immune destruction, would be passed on. And there have been some data to suggest that indeed in the United States, HIV may be becoming more rather than less virulent over time. This is not the case, however, in Africa. They looked at Botswana and South Africa and found that in those populations there has been a shift in the virus. Now, people who are HLA-B 57 are protected against HIV, or at least have more ability to cope with it. The virus has evolved to bypass the protection of those HLA types, and subsequently it has less replicative capacity. So at a population level in Botswana, the HLA type has led to a less aggressive HIV to overcome the underlying genetic resistance, where perhaps in the United States it's become more virulent because that has not been the issue. As always, the issue is complicated. However, if you're HLA-B52, you have to suffer from rock lobster. Again, it's not Ebola that frets me. I would worry more about chikungunya, which is indeed coming our way. It is in Puerto Rico, where this summer it caused over 10,000 cases at a rate of 282 per 100,000 residents. That's pretty good. And it's now in South Florida, according to the CDC. Although South Florida has had a lot of imported cases, they've had 11 cases of chikungunya spread in people who have never left South Florida. There were 2 in Miami-Dade County, 4 in Palm Beach, 4 in St. Lucie, and 1 in Broward County. Given the ubiquity of the mosquito to spread chikungunya, I suspect that chikungunya is going to become a real problem in the next couple of years, especially in the South. So far in Portland and in Oregon in general, we have not seen the mosquito-borne illness that goes by the name of West Nile virus, even though it's ubiquitous in the rest of the United States. My hypothesis is that it is the hops in our beer that keeps it away, and I hope that it works for the chikungunya as well. False positive antibodies are well known to occur with chronic hepatitis C, but it also occurs with a variety of acute hepatitises. This study looked at people with acute hepatitis of a variety of types and found that they not infrequently had a false positive antibody to other diseases, including HIV, HTLV, rheumatoid factor, RPR, CMV, hepatitis E. So in someone who has an acute viral hepatitis, and of course you check this humongous panel to see why, some of the testing may result in false positives. which is always a pain with all serologies. Part of that panel that you get for the acute hepatitis in this day and age should probably include serology for hepatitis E. Now, it is a real problem in Western Europe, and there was a recent study to show it was not an uncommon cause of hepatitis in non-traveling, immunocompetent Netherlanders, if that's what you call someone from the Netherlands. Of 4,067 samples submitted for hepatitis testing, 144 were positive for hepatitis E. This is almost certainly under-recognized in the United States as well. And besides A and B and C and EBV and CMV, so as long as you're sending off multiple tests, you might as well send off the hepatitis E as well, especially, of course, if they have contact with pork and pork products. That's the major source often of hepatitis E. It is flu season, and I was hopeful it would be a quiet one, but it looks like there's a new H3 wandering around that is not covered by the vaccine about half the time. So the vaccine only covers about 2.5 to 2.75 of the strains circulating currently. That's if you get the trivalent. It's more if you get the quadrivalent. Contrary to the myths out there, that does not mean that the influenza vaccine is not effective this year. It's just slightly less effective. And that's a bummer because H3s are more associated with vascular events. As long as we're on the topic of influenza, there was a bummer of a study out to show that IV Peramivir, Peramivir, was no good in the treatment of influenza in hospitalized patients. So as an IV formulation in a randomized trial, it made no difference in outcomes, which is somewhat of a bummer. You still need to rely upon vaccinations, which is still the best way for preventing flu. How good is it? Boy, that's a segue, huh? Well, you can always quibble over the methodology, but the CDC estimates that last season the flu vaccine prevented 3 million medical visits and 90,000 hospitalizations. And that's with a vaccine that is meh when it comes to efficacy, with an overall efficacy rate of around 60%, but unfortunately in the elderly, only about 39%. What we really need is a better vaccine. The one we have is but we need better. It doesn't help that people don't have good confidence in the flu vaccine. Interestingly, 40% think that getting the flu vaccine can give you the flu, which is biologically impossible. And it doesn't help that when you provide information, accurate information about vaccines, it doesn't lead to people changing their mind. It still flabbers my gaster how many people's minds are not changed when given accurate data about, say, the flu vaccine. People are just immune to reality. It's remarkable. It's especially interesting because, at least in college-age students, nobody covers their cough appropriately. Well, not nobody. But this study looked at college students and cough and sneezing etiquette, and men were likely just to go ahead and cough and sneeze right into the air, at least more likely than women. And even when they did cough and sneeze, they often did it right into their hand where they could then spread it to others by direct contact. People are not only recalcitrant to reality, but they're pigs as well. But we all know that. And a while back I mentioned I couldn't figure out why they used the word grip when looking for influenza-related symptoms on, I think it was the Twitters. And it turns out that's the Spanish word for influenza, or at least a flu-like symptom. So they were searching for Spanish words, not using archaic terms to search for influenza. Duh. One of my listeners pointed out my monolingual ignorance. What a surprise. A large study showed that girls who got the HPV vaccine were no more likely to have risky sexual behavior than those who did not. Pregnancy and STD rates were equal in vaccinated and unvaccinated populations. And it was a study that looked at 128,000 girls. I remain puzzled as to why people think that a vaccine to prevent an STD would increase sexual activity, given that the history of the world and the history of STDs and the 7 billion people wandering around the planet right now suggests that the potential downsides of sex do not appear to be a preventative. So there are labs that specialize in Lyme testing. There was a study in CDC that compared a university lab, a standard lab, and 2 Lyme labs for how good their testing was. They found that in terms of the standard 2-step, ELISA followed by Western blot, that all the labs were equivalent. However, the Lyme disease labs had their own interpretation of the Western blot, that while increasing sensitivity came at a, quote, unacceptable price, a steep decrease in specificity, with 37.5% of normal healthy controls having met their IgM criteria, 27% meeting their IgG criteria, and 57.5% of healthy controls meeting one or the other. So there's way too many false positives with the increased sensitivity of the criteria used by the Lyme labs for their testing. The accompanying editorial to the paper makes the excellent and always forgotten point that serology does not diagnose a disease, that if you have low pretest probability, that your chance of having a positive be a true positive is low, and that a lot of Lyme testing gets done in patient populations who have no reason to suspect Lyme and are therefore more likely to have a false positive. I tend to think of human beings as Pigpen from Charlie Brown. We're all in a haze of all time of bacteria and shedding skin cells, and that contaminates our environment. Not unsurprisingly, wherever we put our hands picks up bacteria. And people love to culture specimens and other surfaces, and look, there's something bad growing there. Recently, somebody went around and cultured, I believe it was doorknobs and door handles around hospitals, and found pathogens in the stores. So maybe that's where these bugs are coming from. Now they've gone out and cultured buses. In this study, cultured 237 samples from 40 buses, and I'm shocked to find that they actually found Staph aureus. And of those, 63% had MRSA, finding both the community-acquired MEC4 and the hospital-acquired MEC3 genes as causing their MRSA on the bus. So when people take the bus into the hospital, they're bringing MRSA in with them. The whole world is covered with a fine patina of human bacteria. You can no more avoid it than you can avoid air. That's why you do hand hygiene. If you clean your hands before and after entering a room, you don't have to worry that the staph you picked up on the bus or the Pseudomonas you picked up in the water or whatever wanders into the patient room. What a concept. You know the mantra. The plural of anecdote is anecdotes, not data. And so 7 cases of anything and outcomes are at best a curiosity. This is 7 cases of severe and complicated C. difficile. How were they treated, you might ask? Well, 4 out of 5 were treated with a novel triple therapy, consisting of metronidazole, vancomycin, and IV tigecycline, and 80% were cured, i.e. 4 out of 5. There are other small case series of patients with bad C. difficile being successfully treated with intravenous tigecycline, so I'm not necessarily poo-pooing it. What a joker. But it is something to consider in our armamentarium in the treatment of refractory C. diff, and anything has to be cheaper than fidaxomicin. The other mantra, of course, one of many I suppose, is association is not causation. Yet there's a nice study to again show that vitamin D deficiency is associated with community-acquired Clostridium difficile. I sit here on a cloudy, overcast, rainy day in the great Pacific Northwest, knowing that my vitamin D levels are plummeting rapidly, and I must replete them with ice cream. But it is important to remember that vitamin D is an important cofactor in the immune system, and keeping one replete is a good idea. Think sink. We've had, over the years, infections that I have related to the sinks in my ICUs. Usually it has been the faucets that have been the source. This was an outbreak that had pseudomonal infections associated with contaminated sink drains, and they grew the same Pseudomonas out of the sink drains. Always keep in mind with gram-negative rods like Pseudomonads and Serratias and that sort of thing, that if you get a case in your hospital, the source may be the water in and around the patient. Our water is clean. It's not sterile. Unless, of course, you mix it 50-50 with some scotch. Now that might raise patient satisfaction scores. Time for a little rant. There's a study that showed the non-inferiority between azithromycin and amsulbactam for aspiration pneumonia. What, you might ask, was this aspiration pneumonia? What was old people with known aspiration events who presented with a pneumonia? The pathogens in this study? Well, Strep pneumoniae predominated, followed by Haemophilus, E. coli, some staph, and about half of whom had no microbiologic etiology. I suspect that what these patients had was aspiration and pneumonia. The term aspiration pneumonia tends to be used, I think, too sloppily. A true aspiration pneumonia is someone with funky meth teeth who loses consciousness and presents with a lung abscess. All pneumonias at heart are aspiration. That's how the pathogen gets into the lower airway. It doesn't teleport in there from Mr. Scott on the Enterprise. All bacterial pneumonias are aspiration. So people are so sloppy in their terminology. For me, an aspiration pneumonia is an anaerobic lung abscess with empyema, and anything else is just plain pneumonia. So the patients got better whether they got Augmentin or they got azithromycin. Quelle surprise. They had pneumonia. They got treated for pneumonia. The aspiration probably, I bet, had nothing to do with it. I would like to outlaw the term aspiration pneumonia because as used today, it adds nothing whatsoever to the understanding of the etiology of pneumonia. But of course, that's never going to happen. The efficacy of prophylactic antibiotics to prevent endocarditis has always been in doubt, such to the point where recently the number of people recommended to receive prophylactic antibiotics has dropped dramatically. So what they did in England is they looked at the rates of endocarditis following the new guidelines, which essentially abandoned prophylactic antibiotics in most cases. And interestingly, after introducing the new guidelines, the number of prescriptions for prophylactic antibiotics fell from a surprisingly high 10,900 per month down to about 2,200 a month. And shortly thereafter, endocarditis rates started to increase. And by March 2013, they state there are 35 more cases of endocarditis a month than would have been expected based on prior data. So it would appear in a population-based study that the use of prophylactic antibiotics, at least in England, was beneficial in preventing endocarditis, and that stopping them led to an increase in cases. Although, as they note, it does not establish a causal association, it is certainly concerning. It helps demonstrate the difficulty in determining whether rare events like endocarditis can be prevented by prophylactic antibiotics. Because certainly the data to date suggests that it did not. But you know the rule, for every study there's an equal and opposite study. But still intriguing nonetheless. Infectious diseases are always a balance between the host, the virulence of the organism, and the efficacy of the antibiotic. It is why, in my mind, it's always best to treat with a maximal amount of antibiotic for as short a duration as possible if you want to decrease the emergence of resistance and really give the host immune system a chance to help out. It is popular to give thrice-weekly antitubercular therapy. I've always been concerned about that because the less often you give antibiotics, the more likely you are to get inadequate blood levels and breed resistance. This study found that HIV patients who are on thrice weekly antibiotics developed acquired rifampicin resistance. One wonders if they were on daily antibiotics, where you were nuking the MTB constantly, if that would have happened. They found that HART did help that issue, but they still developed acquired resistance to rifampicin on thrice weekly. I still think thrice weekly antibiotics for TB is a bad idea in any population. You're giving the bug a chance to recover, you're relying upon absorption, and there's been data to show that blood levels are associated with better outcomes, and you may not get that with thrice weekly. It all is a matter of what you can get away with as opposed to what is optimal. And in places like India, where this study was done, you're often stuck with what you can get away with because of limitations in resources. What's better in treating a Candida infection, an azole or an echinocandidin? Now, this study was a meta-analysis of all the studies looking at that issue and found them to be equivalent. Of course, it was, unfortunately, a hodgepodge of echinocandidins, anidulafungin and micafungin and caspofungin, and a hodgepodge of azoles, itraconazole, fluconazole, voriconazole. So I'm not exactly certain you're comparing apples to apples, maybe apples to pear apples or something, I don't know. There's some fruit-related metaphor there I should be able to come up with, but I'm too deficient in my vitamin D because of the rain to think clearly. But the bottom line of this meta-analysis is that there is no difference between echinocandidins and azoles in the treatment and prophylaxis of Candida infections. I think, however, that the heterogeneity of the medications makes such a statement iffy at best. A hodgepodge of drugs, a hodgepodge of Candida, and a hodgepodge of hosts, I think, makes definitive statements questionable. I'm becoming increasingly unenamored of the fungal blood tests that we have for the diagnosis of Aspergillus and Candida and the like. I had a recent patient who had a 1,3-beta-D-glucan come back greater than 500, and he had 0 risk factors for candidemia. I repeated the test, and it was indeterminate 68 2 days later. Now, how about galactomannan assays, you ask? This study looked at doing serum galactomannans in hematology patients who were already on prophylaxis and found that in asymptomatic patients, all of the galactomannan tests were probably false positive. This also gets to the importance of ordering tests in the right clinical scenario so that you know that a positive is a true positive and not a false positive. But as they say, and this is so important, the low pretest risk, there's the keys concept, the low pretest risk of invasive aspergillus in the context of effective anti-mold prophylaxis renders serum galactomannan surveillance of asymptomatic patients unreliable. As in all testing, you should get the test in the patient that has the clinical syndrome that matches the disease so that you know that the test is a true positive and not a false positive. Basic medicine, I suppose, but often ignored. There have evidently been cases of leishmania isolated in Thailand. They have another case of someone who has leishmania martinquensis, a form of leishmania normally found in the Caribbean islands of Martinique. How did those two get there? I had long thought that leishmania in the New World and leishmania in the Old World were separated as the Atlantic was formed and evolved separately. However, the interesting genetics show that leishmania probably got into the New World with human beings as they came across the Bering Sea and then down into South America. And that some of the strains came over from Europe after trade started and started disease in there. So the spread of leishmania across the world has been from both human migrations and from human trade. It's really cool. They found a prehistoric leishmania in the proboscis of a sandfly that had been preserved in sap for thousands of years, and they did genetic analysis on that leishmania to show where it came from. Some of the things about ID are just too cool for school. I wrote about that on one of my Medscape blog entries. Boy, this sounds like fun. Not. They have game farms in Iowa that have wild boars on them. This guy went out and, manly man that he is, killed himself a wild boar on an Iowa game farm. Somehow that just sounds like cheating. Anyway, after that, he processed the meat and then developed GI symptoms, as did members of the family. And they all got Trichinella spiralis, and it was from the wild boar. So, at least it didn't come down with hepatitis E or brucellosis. But if you're out there hunting your wild boars in the Iowa game farm, just remember, wild animals have wild parasites. Wild boar. I wonder what kind of infections you get from shooting fish in a barrel. Sounds about the same. And that brings what is probably the last podcast for 2014 to a close. Looking at my schedule, I'll probably be doing the next one on the weekend of January 3-4, which will take us into 2015. As always, this podcast is brought to you by Pusware LLC over at edgydoc.com, where you can find links to my growing multimedia empire. And if you're bored, of course, what are you supposed to do? You're supposed to write me glowing reviews on iTunes. Otherwise, go to the Society for Science-Based Medicine to check out the organization we are trying to grow there. I am BTW, the president. The references are also over at edgydoc.com. And as always, thank you for this most interesting consultation and allowing me to care for this difficult and challenging case. I shall continue to follow along with you. Thank you in dictation, and goodbye.